Hello, I'm Dr. Roger Henderson, and I'm one of the hosts of the GPnotebook study groups. Welcome to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, in this episode, I'm going to be discussing plantar fasciitis, one of those diagnoses that it seems nearly every doctor encounters, regardless of speciality, although it does appear very frequently in our primary care surgeries. Now, despite its prevalence, it's often misunderstood, oversimplified, or incorrectly framed as a purely inflammatory condition. So I want to take a closer look at plantar fasciitis now as a clinical entity, explore its epidemiology, underlying pathology, diagnostic approach, and our evolving management strategies, all the time whilst emphasising practical insights that are relevant to our daily medical practice. Now, plantar fasciitis accounts for up to 15% of all foot complaints that require professional treatment, and in athletic populations, and particularly amongst runners, plantar fasciitis represents a significant proportion of musculoskeletal injuries. Now, even in the general or sedentary population, up to 1 in 10 people will experience it at some point during their lifetime, and the majority of affected patients are working adults between the ages of 25 and 65, with the peak incidence observed in middle-aged individuals. Epidemiological data also suggests a higher prevalence amongst women, amongst individuals with an elevated body mass index, and in those whose occupations require prolonged standing or weight bearing. Now, from a clinical standpoint, plantar fasciitis has traditionally been considered an overuse injury caused by repetitive microtrauma and damage to the plantar fascia, although the exact etiology of the condition still remains unknown. However, it's perhaps most readily understood as an overuse-related condition driven by repetitive mechanical stress. The plantar fascia functions as a critical static and dynamic stabilizer of the foot's longitudinal arch, and with each step it undergoes tensile loading as it supports our body weight, and it facilitates efficient gait mechanics. Now, over time, excessive or abnormal loading can exceed the tissue's capacity for repair, leading to microtrauma at its origin on the medial calcaneal tubercle. Now, while repetitive strain remains the most common mechanism, plantar fasciitis may also develop following direct trauma or as the result of multiple contributing factors that act simultaneously. Several biomechanical abnormalities can also increase the risk of developing it. So individuals with pes planus, for example, experience increased strain at the origin of the plantar fascia due to prolonged pronation and arch collapse during stance. And conversely, those with pes cavus often lack sufficient shock absorption, resulting in excessive focal loading at the heel. Limited ankle dorsiflexion, frequently caused by tightness in the gastrocnemius and soleus muscles, further exacerbate plantar fascial stress by altering normal gait mechanics. And excessive pronation or supination, prolonged standing, jumping activities, and especially sudden increases in training intensity can all contribute to cumulative tissue overload. I think it's also worth mentioning that muscle tightness in the posterior chain is a particularly important and often underappreciated contributor here. So, a shortened calf musculature restricts ankle motion and increases tension, transmitted through the plantar fascia during a toe-off movement. And this biomechanical relationship helps explain why stretching programs that target both the plantar fascia and the Achilles tendon complex are central to treatment. In addition to mechanical factors, plantar fasciitis is more common in people with obesity, advancing age, and heel fat pad atrophy, all of which reduce the foot's ability to dissipate impact forces effectively. Now, although plantar fasciitis has been associated with seronegative spondyloarthropathies, most cases do occur in the absence of systemic disease. And in fact, no identifiable systemic factor is present in the majority of patients. And this underscores the importance of local biomechanical and lifestyle contributors, although if one is found to be present, it's more likely that the fasciitis will be bilateral. One frequently misunderstood aspect of plantar fasciitis is the role of calcaneal heel spurs. And imaging studies reveal that approximately half of patients with plantar fasciitis do indeed have heel spurs. However, these spurs are not the source of the pain. We must remember that many asymptomatic individuals have significant heel spurs, and many patients with classic plantar fasciitis do not. So, rather than being causative, heel spurs are best viewed as an incidental finding or a marker of chronic traction at the plantar fascia insertion. Now, the pathophysiology of plantar fasciitis further challenges the traditional inflammatory model that's suggested by its name. Histological studies, in fact, demonstrate that plantar fasciitis is primarily a degenerative process. Tissue samples reveal collagen disorganization, fibroblastic proliferation, microtearing, and granulation tissue, actually with minimal evidence of acute inflammation. And these findings have now led many specialists to favour the term plantar fasciopathy, emphasising degeneration rather than inflammation. And this distinction does have important implications for treatment, as it helps explain why anti-inflammatory therapies alone are often insufficient for long-term symptom resolution in our patients. And imaging findings do appear to support this degenerative paradigm. Ultrasound frequently demonstrates thickening and heterogeneity of the plantar fascia, along with calcifications and intrasubstance tears. And MRI scans may reveal chronic degenerative changes or evidence of a prior partial rupture. So these structural abnormalities, combined with evidence of dysfunctional local vasculature, all suggest impaired tissue healing rather than an ongoing inflammatory response. And so clinically, this does explain why patients often experience pain during periods of rest, such as the first steps in the morning, when a shortened and stiffened fascia is then suddenly loaded. So looking at symptoms now, patients presenting to us with plantar fasciitis typically report gradually progressive pain localized to the inferior and medial aspect of the heel. And the pain is often described as sharp or stabbing, particularly with initial weight bearing after a period of inactivity. And I've found that morning pain is a hallmark feature here, but symptoms may also worsen after prolonged sitting or standing. Many patients will note a temporary improvement in their symptoms with the onset of walking or exercise, only to experience increasing pain as their activity continues throughout the day. And in more advanced cases, discomfort may actually radiate into the arch or proximally along the foot. Physical examination often reveals focal tenderness at the medial calcaneal tubercle, and pain is commonly reproduced with passive dorsiflexion of the ankle and toes, which increases tension on the plantar fascia. A positive windlass test, where there's pain on dorsiflexing the first metatarsophalangeal joint, is frequently positive and can help support the diagnosis. Additional findings may include a tight Achilles tendon, altered foot posture, or gait abnormalities reflecting compensatory mechanics. Now, given the non-specific nature of heel pain, as GPs we should remain vigilant for alternative diagnoses here, such as calcaneal stress fractures, fat pad atrophy, nerve entrapment syndromes, infection, or neoplastic processes, particularly when symptoms or exam findings are atypical. You can do a lateral squeeze test here to rule out a stress fracture. A positive result occurs when pain on lateral compression of the heel is greater than inferior heel pain, and that's suggestive of a stress fracture. I would always exclude pain from a lesion at the S1-2 level by doing a straight leg raising test as for examination of the back, and always check the ankle tendon reflex, S1, and calf strength 2 by asking the patient to walk on tiptoe or stand on one leg and raise the heel off the floor. These tests should be normal. Palpate the back of the heel and the ankle to exclude an Achilles tendonitis, and remember to press together the heads of the second and third metatarsals and then the third and the fourth, as any reproduction of the pain here can suggest a Morton's neuroma. But in most cases, plantar fasciitis is a clinical diagnosis, and imaging isn't required initially, and there's no laboratory test that can confirm or rule out the diagnosis. In fact, plain film X-rays of the foot are usually of little benefit in typical cases of plantar fasciitis, but can be ordered if there's a suspicion of a stress fracture or an alternative cause of heel pain, or if there's a history of trauma. X-rays or ultrasound may be considered too when symptoms persist despite appropriate conservative management. An ultrasound is particularly useful here for demonstrating thickening of the plantar fascia and structural changes, while an MRI scan is usually recommended in cases of recalcitrant heel pain, by which I mean pain lasting for more than 12 months, or if there are any soft tissue or osseous masses palpated or visualized on other imaging studies. Advanced imaging may also help identify partial tears, stress fractures, or osteochondral abnormalities when conservative therapy fails. I'd also suggest testing for rheumatoid factor, an anticyclic citrullinated peptide antibody here, if there are any clinical or radiographic signs suggesting rheumatoid arthritis. And I'd test for HLA-B27 too if there's any suspicion of a spondyloarthropathy, such as an axial spondyloarthritis or a reactive arthritis. Now, the management of plantar fasciitis should always follow a structured, stepwise approach with an emphasis on patient education and realistic expectations, with the goal of treatment being complete pain relief. Initial treatment focuses on relative rest and modification of any aggravating activities, but tell your patient that complete immobilization is rarely necessary, but excessive loading should be avoided if possible. Ice applications and short-term use of non-steroidal anti-inflammatories may provide symptomatic relief, although these don't address or alter any underlying degenerative process. Stretching, though, plays a key role in recovery. Programs targeting the plantar fascia, Achilles tendon, gastrocnemius and soleus muscles are supported by evidence, and these address key biomechanical contributors. Footwear modification is equally important, as shoes with appropriate arch support and cushioning can significantly reduce plantar loading. Orthotic devices, heel cups, and night splints may all further reduce symptoms, particularly in patients with significant morning pain, and manual therapy techniques, including deep tissue massage of the plantar fascia and the surrounding structures, may also provide additional benefit when combined with stretching and load management. Now, for the majority of our patients, conservative therapies do prove to be beneficial in relieving heel pain. But when these fail to produce any meaningful improvement after several weeks, more advanced interventions may then be considered. Extracorporeal shockwave therapy has shown promise in some studies, although the results are variable, and NICE state that although the evidence on it for refractory plantar fasciitis raises no major safety concerns, the current evidence on its efficacy is inconsistent. Injection-based therapies, including corticosteroids, platelet-rich plasma, prolotherapy, and botulinum toxin, have all been used with varying degrees of success, and of these, corticosteroid injections are perhaps the most frequently used in the short term for the acute pain management of plantar fasciitis, and these are considered if conservative treatment leads to inadequate pain relief or if the pain is especially high on initial presentation. However, although they have been shown to be helpful in relieving pain, most studies do report only short-term rather than any sustained benefit, and their risks include plantar fascia rupture and fat pad atrophy, so we should always be using these judiciously. You can look at surgical intervention, but this is reserved for a small subset of patients with chronic refractory symptoms who have failed prolonged non-operative management. Various surgical techniques now exist, such as partial or complete plantar fascia release with or without calcaneal spur resection, excision of abnormal tissue, and nerve decompression. And favourable outcomes have been reported in more than 3/4 of patients, although their recovery time is often slow. Unfortunately, persistent pain may occur in up to 1/4 of patients 2 or more years after surgery, and potential complications include nerve injury, arch destabilization, and persistent pain. And this reinforces the importance of exhausting all conservative options before we consider surgery. Fortunately, the prognosis for plantar fasciitis remains generally good, with around 3/4 of patients achieving symptom resolution within 1 year. But the recovery process can be prolonged, and the functional impact here should not be underestimated, as many patients experience significant limitations in work, physical activity, and their overall quality of life during the course of the condition. So fortunately for us, effective management does hinge on patient education, and this can be easily done. Patients should understand that plantar fasciitis is often self-limiting, but it requires considerable patience and adherence to therapy, emphasizing the gradual progression of activity, consistent daily stretching, appropriate footwear, and weight management can all help prevent recurrence. And we should also be mindful that whilst advanced therapies may be appealing, their evidence base still remains mixed, and so treatment must be tailored to the individual. So just pulling this all together now then, plantar fasciitis is a deceptively simple diagnosis with complex biomechanical and pathological underpinnings, and recognizing it as a degenerative condition rather than a purely inflammatory one allows for more effective counseling, more appropriate use of therapies, and better long-term outcomes. By taking a comprehensive, patient-centered approach, as GPs, we can help our patients navigate what's often a frustrating and prolonged recovery, ultimately restoring their function and reducing the burden of this common condition. So that's a broad overview of plantar fasciitis, and I do hope you found it helpful for the next time you see a patient with this common condition. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@gpnotebook.com if you have any questions, comments, or ideas for future podcasts, as we really do like to hear from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you so much for listening, and goodbye.